So before starting the session, I wish you all a very happy new year, right? And we will have a very good beginning of this particular session. And we wish the entire year should go with the same new beginning, which is like very good. Right, let us start with the session. So today will be the neurology. So if you take the first question, right, you see this first question. This is the first question for the day. So the question is, which of the following is the earliest manifestation seen in case of the Guillain-Barre syndrome? Distal areflexia, then truncal paralysis, facial diplegia, bulbar palsy. Which of the following is the earliest manifestation seen in Guillain-Barre syndrome? Yes, the earliest manifestation which is seen in patients with the Guillain-Barre syndrome will be the distal areflexia, right? So distal areflexia, that is the earliest manifestation that you come across in patients with the Guillain-Barre syndrome. Now, so we'll do a quick revision of the entire Guillain-Barre syndrome in hardly around 4 to 5 minutes, okay? Then I'll do a quick revision in just 1 minute later after the completion of the Guillain-Barre syndrome. Now, if you take this Guillain-Barre syndrome, right, what exactly it is a demyelinating disorder, okay? It is a demyelinating disorder, and this particular demyelination, it is of the peripheral nervous system. You have two important demyelinating disorders in the neurology. One is multiple sclerosis and the other one is Guillain-Barre syndrome. So you take multiple sclerosis, it's a demyelinating disorder of the central nervous system, whereas Guillain-Barre syndrome, it's a demyelinating disorder of the peripheral nervous system. That is a very important difference between these two. And this Guillain-Barre syndrome, it's an autoimmune condition, right? And it's an autoimmune disorder, and where the antibodies are formed against the organisms, right? That is your Campylobacter jejuni and as well as the viral infections, okay? So the most common organism will be the Campylobacter jejuni, right? Before starting this particular session, let me just give you a quick note that the PDF of this particular system, that is the neurology, I have posted it on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So you can download this PDF from my Telegram channel. All right. Okay. So now it is an autoimmune condition where the antibodies are formed against the organisms like Campylobacter jejuni and as well as the viral infections, cytomegalovirus and as well as the Epstein-Barr virus and HIV. The antibodies which are formed against these organisms, they cross-react with the myelin sheath of the peripheral nerve, causing demyelination. And it's an acute inflammatory demyelinating disorder. This word is very important. It's an acute inflammatory demyelinating disorder. And the antibody formation and as well as attacking the myelin sheath is not immediate. This will take almost 7 to 10 days. That is the reason why it is considered as a delayed hypersensitivity reaction, that is a type 4 hypersensitivity reaction. So in the pathogenesis, what do we consider this as? In the pathogenesis, we consider this as the molecular mimicry. In pathogenesis, it is molecular mimicry, where the antibodies which are formed against the organisms are attacking the myelin sheath of the peripheral nervous system of the human being. Now, if you take the clinical manifestation, these patients, they will be having symmetrical motor weakness, right? Symmetrical motor paralysis. And that too, where this paralysis will start with. This particular paralysis, it will start in the lower limbs. And followed by that, the paralysis will gradually ascend upwards in the truncal muscles and as well as the upper limb muscles. This is what is called ascending type of paralysis. And what are the muscles which are affected last? The muscles which are being affected last will be your respiratory muscles. So once there is respiratory muscle paralysis, these patients will result in what is called type 2 respiratory failure. Now, these patients with the Guillain-Barre syndrome, they also have the autonomic dysfunction. And because of the autonomic dysfunction, the manifestations in these individuals will be in the form of either tachycardia or bradycardia can be there. And not only that, there will be facial flushing and as well as fluctuating blood pressure. And what is this fluctuating blood pressure? That is, these patients will have orthostatic hypotension and they can also have resting tachycardia. And is there any cranial nerve involvement in Guillain-Barre syndrome? Yes. What is that most common cranial nerve which is affected? The facial nerve is the one which is commonly affected. Then how will you diagnose this Guillain-Barre syndrome? You have many investigations, but what is the investigation of choice is the antibody, right? That is anti-GM1 antibody is being formed, right? Now, the CSF analysis, when you do in these individuals, this will show you the presence of the albuminocytological dissociation, right? This will show you that there is albuminocytological dissociation. What do you mean by this albuminocytological dissociation? That means the protein levels will be very high, but the cell count will be normal. Cell count will be normal. And this is what is called as the albuminocytological dissociation. All right. Now, the very important is the patients have to be treated immediately. Now, what are the options for the treatment? The options for the treatment in these individuals is the plasma exchange, where we do plasmapheresis and will remove the existing antibodies. And what exactly is the drug of choice? Right? Drug of choice in these patients will be the intravenous immunoglobulin. That will be the drug of choice, right? You have two options of the treatment, either plasmapheresis or the intravenous immunoglobulin. But this intravenous immunoglobulin is very expensive, and those individuals who are not able to afford the intravenous immunoglobulin, in them the plasma exchange has to be done. Then how is the prognosis in these patients? Please remember, these patients, they will have generally a very good prognosis. Within 2 to 3 weeks, there will be recovery of this particular weakness. And how will be the clinical presentation in these patients? There will be acute flaccid paralysis will be the clinical presentation, and that too it will start with the lower limbs. And within 2 to 3 weeks, the weakness will recover back. But in 5% of patients, right, in 5% of patients, there can be mortality mainly because of the involvement of the respiratory muscles. Now, which group of individuals are said to have poor prognosis? Those individuals who are having the age more than 40 years, then those individuals who have the diarrheal illness caused by Campylobacter jejuni, and those individuals who had required mechanical ventilatory support because of type 2 respiratory failure. These three individuals or these three patients are considered to be the one who are having poor prognosis in patients with the Guillain-Barre syndrome, right? Now, in these patients with Guillain-Barre syndrome, like we have 4 subtypes. What are those 4 subtypes? One is acute inflammatory demyelinating polyneuropathy. Then you have ASMAN, that is acute sensory motor axonal neuropathy. Then followed by that, AMAN, that is acute motor axonal neuropathy. And we have one rare condition that is called the MFS, that is Miller-Fisher syndrome, right? And which is the most common form? The most common form will be the AIDP, acute inflammatory demyelinating polyneuropathy, right? Which is the rare form? The rare form will be Miller-Fisher syndrome. Now, how is this Miller-Fisher syndrome slightly different from the Guillain-Barre syndrome is? In case of the Guillain-Barre syndrome, we have discussed that it is the common cranial nerve which gets affected is the facial nerve. But in these individuals with Miller-Fisher syndrome, these patients, they will be having ophthalmoplegia, right? And what could be the reason for the ophthalmoplegia? That is because of the involvement of the third I'm sorry. That is due to involvement of the third cranial nerve. The individual will have ophthalmoplegia. Okay. So this is about Guillain-Barre syndrome, right? And yes, Rituraj Sahu, they will be requiring the scheduled plasmapheresis. Scheduled plasmapheresis is the treatment that is done in these individuals. But this plasmapheresis is being done in those individuals who are not able to afford for the intravenous immunoglobulin, right? So this is about the Miller-Fisher syndrome. Sorry, this is about the Guillain-Barre syndrome. So in 1 minute, I'll just quickly recap the entire Guillain-Barre syndrome. It is a demyelinating disorder of the peripheral nervous system. And it's a type 4 hypersensitivity reaction. And it's an acute inflammatory demyelinating polyradiculoneuropathy. And the pathogenesis will be molecular mimicry. The common triggers will be Campylobacter jejuni, which is most common. Clinical manifestations will be the acute flaccid paralysis. That too, it will start in the lower limbs, and there will be ascending paralysis. And the last to be affected will be respiratory muscles. And the cause of death in these individuals will be mainly due to respiratory muscle paralysis. Autonomic dysfunction can be there, and that will result in the sinus tachycardia or bradycardia and postural hypotension. Cranial nerve involvement, most common will be the 7th cranial nerve. And the antibody that will be anti-GM1 antibody, CSF analysis will show you that there is albuminocytological dissociation. And the treatment options that we have in these individuals will be plasmapheresis, and intravenous immunoglobulin is the drug of choice. And prognosis is generally good. And poor prognostic factors will be age of the individuals more than 40 years, previous diarrheal illness, and as well as the requirement for the ventilatory support. Okay, these are the poor prognostic factors. So we are done with the topic related to Guillain-Barre syndrome. Now, we'll move on to next topic, that is the myasthenia gravis. Anti-acetylcholine receptor antibody, anti-MuSK antibody, anti-LRP4 antibody, anti-netrin 3 receptor antibody. Yes, which of the following antibody is not observed in case of, Rituraj Sahu, I'm slightly sick. I'm just having a little cold, but it's okay. It's manageable, no problem. Right. So, yes, the antibody which is not seen in case of the myasthenia gravis will be the anti-netrin 3 receptor antibody. Now, let me tell you what are all the way. This myasthenia gravis is also an autoimmune condition where the antibodies are formed against the acetylcholine receptors which are present on the postsynaptic nerve terminal. But in myasthenia gravis, not only as anti-acetylcholine receptor antibody, you also have anti-MuSK antibody and as well as the anti-LRP4 antibodies. Then, what are the other antibody? Right, you see, these are all the antibodies in case of the myasthenia gravis. One is the acetylcholine receptor antibody, right? And the other antibodies are the anti-MuSK antibody, but this is present only in 10% of the individual, right? And the next important is the the other important antibody will be the anti-LRP4, the antibody. But this anti-netrin antibody, if you see, what is the option that has been given to you? The option that has been given to you is anti-netrin 3 receptor antibody. In myasthenia gravis, what is the antibody that you will have is, in myasthenia gravis, you will have anti-netrin 1 receptor antibody. It is not anti-netrin 3. And the other important antibody in case of myasthenia gravis will be anti-COSPR2 antibody. And the other important antibody will be anti-striated muscle antibody. So these are the antibodies that are found in patients with the myasthenia gravis. Okay, just give me 1 minute, guys, 1 minute. The antibodies that are present in case of the myasthenia gravis will be what now? The number one, anti-acetylcholine receptor antibody. Anti-MuSK antibody present in almost 10% of individuals. Then anti-LRP4 antibody. The other one is anti-netrin 1 receptor antibody. And the other one is anti-COSPR2 antibody. And the other one is anti-striated muscle antibody. These are the antibodies in case of myasthenia gravis, right? But in the option, it was given as anti-netrin 3, which is an incorrect statement. Okay. Now, let me totally 6 antibodies. Totally 6 antibodies. Out of these particular 6 antibodies, Rituraj Sahu, the most common one is anti-acetylcholine receptor antibody is present in almost 85% of patients. And this anti-acetylcholine receptor antibody will block the alpha subunit of the acetylcholine receptor. Okay, right? Alpha subunit of the acetylcholine receptor. Very, very important question, right? Now, let me quickly recap the entire topic of myasthenia gravis. So if you take this myasthenia gravis, what exactly is this disorder? This particular disorder, it is a disorder of the neuromuscular junction. And it is actually a type 2 hypersensitivity reaction. And in case of type 2, you have a subtype. And what is that subtype? That particular subtype, it is a type 5 hypersensitivity reaction. And because it's an autoimmune condition, it is more common in females rather than males. And what are the common etiologies, right? It is mainly due to thymus gland abnormalities. It is mainly due to thymus gland abnormalities. And what is the thymus gland abnormalities? In majority of the individuals, it is thymus hyperplasia. And followed by that, in 10% of individuals, it is thymoma. Now, what will be the important clinical manifestation? The clinical manifestation in these patients will be in the form of the fluctuating weakness of the voluntary muscles. Now, if you see this particular question, what is the muscle which gets affected first? It is the ocular muscles which gets affected first. And within the ocular muscle, it is the levator palpebrae superioris muscle which gets affected first. And because of this, these patients, the earliest manifestation in patients with myasthenia gravis will be in the form of ptosis. That will be the earliest manifestation. And followed by this ocular muscles, what are the next important group of muscles? There will be involvement of the facial muscles. And because of the involvement of the facial muscles, there will be myasthenic snarl. These patients, they will have an abnormal smile, and that will be called as myasthenic snarl. And these patients, they will also have muscles of mastication weakness, due to which they will be having jaw claudication. And there will be also involvement of the pharyngeal muscles, because of which the individual will have difficulty in deglutition. And there will be also involvement of the lingual muscles, and because of which the individual will also have difficulty in the speech of the individual. Now, if you take the muscles, the skeletal muscle involvement, it is more or less proximal muscles and as well as distal muscles are also affected. Now, you take pregnancy and as well as the neonatal myasthenia gravis. Now, what happens to clinical features of myasthenia gravis during pregnancy? Please remember, the clinical features of myasthenia gravis, they worsen during the pregnancy. And what will happen to the fetus? The antibodies, they're transferred to the newborn via placenta during the pregnancy. And how is you will diagnose myasthenia gravis? The diagnosis of the myasthenia gravis is, number one, the antibodies. Antibodies are formed against the acetylcholine receptors, which are present on the postsynaptic nerve terminal. And clinically, how will you diagnose? That is diurnal variation. That means early in the morning or during the daytime, he will be completely fine. But as the day progresses, the individual will have the exaggerated weakness, right? But what exactly is the investigation of choice? The investigation of choice in these patients will be single fiber electromyography. That will be the investigation of choice. What the single fiber electromyography will show you, that there will be a decremental response on repeated stimulation. That is what is called single fiber electromyography. And what are the other ways by which you can diagnose myasthenia gravis is, that is by your IcePack test, that will improve the ocular symptoms. And the other one is the hydrophonium test, which is also called tensilon test, which will also improve the ptosis after the application of this particular hydrophonium. Now, if you take the associated conditions, the associated conditions include, number one, thymoma, because it is the disorder which is associated with thymic hyperplasia and as well as thymomas. And because this being an autoimmune disorder, it is associated with other autoimmune disorders also, like it can be associated with rheumatoid arthritis, it can be associated with thyroiditis, and as well as the systemic lupus erythematosus. Okay, then how do you treat these patients with the myasthenia gravis? In case of mild form of myasthenia gravis, we give pyridostigmine, that is anticholinesterases. Okay, that is basically cholinesterase inhibitors, right? Whereas in severe form of myasthenia gravis, we give prednisolone, that is corticosteroids have to be given. And what is the role of thymectomy? Thymectomy should be done in all the individuals between puberty and as well as 55 years of age. That means 15 to 55 years of patients with myasthenia gravis, they have to undergo thymectomy. And we have a clinical condition called myasthenic crisis. Myasthenic crisis mean where there will be involvement of the respiratory muscles, and that will cause the type 2 respiratory failure. And how will you treat this myasthenic crisis? The drug of choice for myasthenic crisis will be the intravenous immunoglobulin. And very important multiple choice question that can be asked is, there are certain drugs which can precipitate or which may exacerbate myasthenia gravis. What are those drugs? That includes penicillamine. Next important is the quinidine, beta blockers, gentamicin, and as well as the tetracycline. So these are the drugs which can exacerbate the myasthenia gravis. Okay, right. Okay, so this is about the complete picture of myasthenia. So let me just quickly recap the myasthenia in just 1 minute. So myasthenia gravis, it's a neuromuscular junction disorder. It's a type 2 hypersensitivity reaction, under which you have a subtype, that is type 5 hypersensitivity reaction. Gender prevalence, if you see, more common in females rather than males. And it is mainly due to thymus gland abnormalities, and that is due to thymic hyperplasia. And symptoms will be fluctuating weakness. The earliest manifestation will be in the form of ptosis, but this particular ptosis will be asymmetrical ptosis. The other muscles which are affected are facial, masticatory muscles, then muscles of deglutition, lingual muscles. Pregnancy, myasthenia gravis worsens. Diagnosis, anti-acetylcholine receptor antibodies are present only in 85% of individuals. The investigation of choice is single fiber electromyography. Then associated conditions include rheumatoid arthritis, thyroiditis, and SLE. In case of mild form of myasthenia gravis, you need to give anticholinesterases, that is pyridostigmine. Whereas in severe form, you need to give prednisolone. Thymectomy should be done in the age group between 15 to 55 years. And myasthenic crisis, you need to give intravenous immunoglobulin. And what are the drugs which will precipitate myasthenia gravis? Penicillamine, quinidine, beta blocker, gentamicin, and tetracycline. Okay, so this finishes the topic related to myasthenia gravis. Okay, now we'll move on to the next question. Okay, you see the next one. We have a 32-year-old female presents to the neurology clinic with history of recurrent episodes of blurred vision. And there is also weakness in her legs and difficulty in coordinating the movements. She reports experiencing intermittent urinary urgency and frequency along with occasional urinary incontinence. On examination, the patient demonstrates signs of internuclear ophthalmoplegia. All of the following are associated with this following conditions except the options are internuclear ophthalmoplegia, 1.5 syndrome, 8.5 syndrome, detrusor hyporeflexia. Okay, so can anyone tell me? Right, so the diagnosis of this clinical scenario is multiple sclerosis, right? And in patients with multiple sclerosis, you will have internuclear ophthalmoplegia. That is due to demyelination of median longitudinal fibers. And there will be 1.5 syndrome in these individuals. And there will also be 8.5 syndrome. That is 7th cranial nerve will be affected along with 1.5 syndrome. Along with 1.5 syndrome. That will become 8.5 syndrome. Okay, and they will not have detrusor hyporeflexia. What they will have is detrusor hyperreflexia will be there in these patients. That's a very, very important point. They will not, patients with multiple sclerosis, they will have detrusor hyperreflexia, not hyporeflexia. Okay, now the topic that we are going to discuss is demyelinating disorder of the central nervous system. Demyelinating disorder of the peripheral nervous system, already we have discussed, that is Guillain-Barre syndrome. Now, demyelinating disorder of the central nervous system, that will be multiple sclerosis. Now, let me just do a quick revision of the entire multiple sclerosis. Right. So, if you take this multiple sclerosis, it is also an autoimmune disorder and it is an immune-mediated disorder where the antibodies, they are formed against the myelin and as well as the myelin sheath and as well as the axon. So the antibodies which are formed against the myelin sheath will cause demyelination. Antibodies which are formed against the axon will also cause damage to the axon. But predominantly it is the myelin sheath which is being affected. But please remember, these antibodies, they cross the blood-brain barrier and they will cause demyelination within the central nervous system. That is the brain and as well as the spinal cord. And what exactly is the etiology? It is commonly observed in patients who are having the HLA association HLA-DR2. And there is also environmental multiple sclerosis, which occurs mainly due to vitamin D deficiency. And not only that, we have some viral infections which can cause multiple sclerosis. That is Epstein-Barr virus. Now, depending upon the pattern of the clinical manifestations in patients with multiple sclerosis, we have totally 4 types. That is relapsing remitting multiple sclerosis, primary progressive, secondary progressive, and progressive relapsing. But which is more common among all these? That is relapsing remitting multiple sclerosis is the most common type of multiple sclerosis. Among the various clinical manifestations that you have in patients with multiple sclerosis, the most common clinical manifestation will be the sensory abnormalities, and that will be in the form of paresthesia, and that will be the initial symptom that you will see in patients with multiple sclerosis. Followed by that, you have the involvement of the optic nerve, and because of which these patients will have optic neuritis, and that can also cause visual impairment that can progress even to the blindness. And the other features that these patients can have is the fatigue and as well as the motor weakness. So what will be the visual symptoms? The visual symptoms include there will be loss of vision, and that is due to optic neuritis. And characteristic feature in patients with multiple sclerosis will be the development of the Uthoff's phenomena. What exactly is this? It is the symptoms of multiple sclerosis which get worsened on exposure to heat is called Uthoff's phenomena. And these patients, they will also have the internuclear ophthalmoplegia. And why is that due to demyelination of median longitudinal fibers? Then, how will you diagnose these patients? The diagnosis of multiple sclerosis, it is mainly by MRI. What does this MRI will show you? That will show you presence of a demyelinating plaques that are present mainly in the periventricular area. And that will give you a picture of a Dawson's fingers, which is a characteristic feature in patients with the multiple sclerosis. And what will be the CSF analysis in patients with multiple sclerosis? There will be oligoclonal bands, which is very characteristic of multiple sclerosis. And because optic nerve is commonly affected, when you do visual evoked potentials will show you that there is delayed latency. That is because of demyelination. So common presenting feature is what? There will be sensory loss and as well as the optic neuritis. Patients with multiple sclerosis have a characteristic sign that is called as Lermite sign. What exactly is that? It is upon flexing the neck, these patients will have the electric shock-like sensation down the spinal cord. That is what is called as the Lermite sign. And how do you think is the prognosis in these patients? Almost 30% of patients, they're having the poor prognosis. They develop physical disability. And how do you treat these patients? Acute episodes of multiple sclerosis, they are treated with the methylprednisolone, whereas chronic cases, in them you need to give the disease modifying therapy, and the drugs include the interferon beta, glatiramer acetate, natalizumab, and as well as the fingolimod. Very important question related to the natalizumab. This particular natalizumab, it is a very important drug that is given in case of relapsing remitting type of multiple sclerosis. What it will do? It will reduce the development of new lesions, and it will also decrease the severity of the disease. That is what is the effect of your natalizumab. Then symptomatic treatment. So these patients, because of demyelination of the corticospinal tract, there can be development of spasticity, for which you need to give skeletal muscle relaxant, that is baclofen and tizanidine. And because of the involvement of the sensory nerve, these patients are having paresthesias, for which you need to give gabapentin and carbamazepine. And these patients, they will have detrusor hyperreflexia, because of which there will be spastic bladder, for which you need to give anticholinergic drugs like oxybutynin should be given. So in the diagnostic criteria, very important is MRI, that will show you a Dawson's fingers, lumbar puncture, that will show you the presence of the oligoclonal bands, and visual evoked potentials will show you a delayed F reflex. And among the variants of multiple sclerosis, we have an important variant of multiple sclerosis that is called Devick's disease, which is called neuromyelitis optica, which I'll be discussing that in detail. And we have another important severe form of multiple sclerosis that is called fulminant multiple sclerosis, which is called Marburg variant. Now, let me discuss both of these variants first. So, if you take this Devick's, which is called neuromyelitis optica, what exactly is the difference from multiple sclerosis? Definitely, these patients will have the optic nerve involvement. Along with the optic nerve involvement, these patients will have the extensive transverse myelitis of more than 3 vertebral segments. That is a very important point in case of your Devick's disease. And the next important is fulminant multiple sclerosis, which is also called Marburg variant. What exactly is this? It is a rapid, progressive, and fatal form of multiple sclerosis. And what will be the problem in these patients? There will be severe axonal damage, inflammation, and as well as necrosis. That is what is your fulminant multiple sclerosis, which is also called Marburg variant. Okay. So with this, we are done with the multiple sclerosis. In 1 minute, I will revise the entire multiple sclerosis. So what exactly is this? It's an autoimmune condition. What is pathogenesis? Antibodies will cross the blood-brain barrier, will cause demyelination of the neurons within the central nervous system. Etiology, mainly HLA-DR2 association, environmental multiple sclerosis due to vitamin D deficiency. Virus causing multiple sclerosis will be Epstein-Barr virus. Most common variant, relapsing remitting multiple sclerosis. Common symptom, sensory loss. Most common nerve affected, optic nerve, causing visual impairment and as well as the blindness as well. Uthof's phenomena, there will be worsened vision on exposure to heat. And because of demyelination of the median longitudinal fiber, there will be INO, internuclear ophthalmoplegia. The investigation of choice, MRI, that will show you a Dawson's fingers. So common presenting symptoms will be sensory loss, optic neuritis, and there will be also Lermite sign. And prognosis, not very good, poor prognosis. Drug of choice in acute episodes will be methylprednisolone, and for RRMS, the preferred molecule for the chronic treatment will be natalizumab, and for spasticity we give baclofen, for sensory paresthesias we give gabapentin. And the CSF analysis will show you that there is oligoclonal bands, and specific variants are Devick's disease, which is neuromyelitis optica, where there will be severe optic neuritis and extensive transverse myelitis, more than 3 vertebral segments. And what is this fulminant multiple sclerosis? A rapid, progressive, and fatal form of multiple sclerosis, right? Yeah. All are the factors contributing to the pathology of amyotrophic lateral sclerosis, except because like kabhi kya hoga, FMG exam also, it is not that very easy exam. FMG exam also, if I still remember, the 2020, if I'm not wrong, there was an exam conducted on August 20th on 2020. It was the toughest FMG paper in the entire, the pattern of the questions that were being asked. Very, very tough paper, right? And that time the pass percentage was something like 8% or 9% was the pass percentage for the FMG students. So we cannot predict like how the papers come. So we need to be prepared with everything for the easy paper and as well as for the tough paper. So that is the reason why I'm trying to revise each and every point of each subtopic. Okay, right. So in case of the amyotrophic lateral sclerosis, let me tell you that these patients will have defective protein degradation in the neuron. There will be defective RNA processing. There will be increased glutamate level. There will be increased glutamate level. But what will happen is they will not have increased methionine level. They will not have increased methionine level. Okay, that is the incorrect statement related to the amyotrophic lateral sclerosis. But the glutamate level will be the excessive. And this excessive glutamate accumulates and it overactivates the glutamate receptor, and that will trigger the calcium influx and subsequent neuronal injury. That is what you observe in case of the amyotrophic lateral sclerosis. And there is no increase in the methionine in the pathology of amyotrophic lateral sclerosis. Now, let me discuss in detail. And one more important substance that will be elevated in patients with the amyotrophic lateral sclerosis will be aspartate. There will be increased glutamate and there will be increased aspartate. Both of these are the excitatory neurotransmitters. Let me discuss in detail about the motor neuron disease. Okay, so motor neuron disease, if you see, what exactly is the age group at which you see this very commonly? Between 30 and as well as 60 years. Now, what is the important structure which gets affected in patients with motor neuron disease is, it is mainly the degeneration of the anterior horn cell, and that is what is responsible for the development of fasciculations, which is a pathognomic feature in patients with the motor neuron disease. And other structures that can get affected is there can be involvement of the lower cranial nerves, corticospinal tract, and as well as the corticobulbar tract as well. And what is the important risk factor for the development of this motor neuron disease? That will be smoking. Very, very important, cigarette smoking. And these patients with involvement of the upper motor neurons, that include corticospinal tract involvement will be there. And what are the structures of the lower motor neuron which undergoes the effect that gets affected in case of motor neuron disease? That will be the anterior horn cell. Upper motor neuron, either corticospinal tract or corticobulbar tract. Lower motor neuron, either anterior horn cell or it can be even the cranial nerves as well. And what are the types of motor neuron disease? Like we have amyotrophic lateral sclerosis, which is the most common type of motor neuron disease, where you have the involvement of both upper motor neuron and as well as the lower motor neuron as well. But there are some disorders where you have only pure motor deficit. I mean to say, this motor neuron disease, you have only motor deficit. The sensory involvement will not be there in patients with the motor neuron disease or amyotrophic lateral sclerosis. So there is no sensory. If at all, if sensory is there, it is not motor neuron disease at all. What is pathognomic feature in patients with motor neuron disease? That is fasciculations. And why is that due to? Due to the involvement of the anterior horn cell. And these patients, they will be having progressive muscular weakness and as well as the atrophy. And how will you diagnose these patients with motor neuron disease? That is by MRI. What it will show you? That there is increased signal intensity in the corticospinal tract. The other ways by which you can diagnose motor neuron disease is electromyography, which will show you the degenerated muscle fibers. And muscle biopsy is not always required. So common symptom is what? Fasciculations. And why is that due to? Due to the involvement of the anterior horn cell. Bulbar palsy. What is this bulbar palsy? Bulbar palsy is that where you have the involvement of the 9th, 10th, 11th, 12th cranial nerve problem. And where will be this 9th, 10th, 11th, 12th cranial nerve? That will be in the medulla oblongata. That gets affected, that will result in bulbar palsy, and thereby these patients will have the features like difficulty in speaking, drinking, and as well as swallowing as well. And these patients will have spasticity, and that is due to the involvement of the corticospinal tract. And these patients, if at all, if they die, what could be the reason for the death? That is respiratory failure. That is a cause of death in these patients. And is there any specific curative treatment? There is no specific curative treatment. It is only supportive treatment that is given in these patients. And what is that supportive treatment that we give? That is mainly, sorry. That is mainly the physiotherapy, and as well as the respiratory care has to be given with the help of ventilator. But there are some drugs, that is riluzole and as well as edaverone. Riluzole will extend the survival of the individual. Edaverone, it will slow down the progression of the disease. And overall, how is the prognosis in these patients? They have poor prognosis. Prognosis is not good. 50% of patients, they die within 3 years, right? And if they develop amyotrophic lateral sclerosis, they die within 4 to 5 years. And if there is development of bulbar palsy, the survival is just only 2 years, right? But there are some gene therapies. But these gene therapies are given for what? That is spinomuscular atrophy. What is the spinomuscular atrophy? Where you have pure lower motor neuron involvement. Actually, amyotrophic lateral sclerosis is that where you have both upper motor neuron and as well as the lower motor neuron involvement. But whereas in SMA, you have lower motor neuron involvement. And we have one more clinical entity called primary lateral sclerosis. In primary lateral sclerosis, it is purely upper motor neuron involvement. And what is the gene therapy that you give in patients with spinomuscular atrophy? It is very expensive therapy. It will cost around 15 to 16 crores. And that particular gene therapy is onasemnogene abipavovec. That is a gene therapy that is approved for children under the 2 years with spinomuscular atrophy. And another important option that we have for the spinomuscular atrophy is nusinersen. So these are the two options of the treatment for spinomuscular atrophy, which is predominantly lower motor neuron involvement. Okay. So with this, we are done with the motor neuron disease. So let me just quickly recap motor neuron disease in just 1 minute. Motor neuron disease, purely motor symptoms, no sensory symptoms at all. Age group 30 to 60 years. The commonly affected structures will be degeneration of the anterior horn cell that will result in fasciculation, which is the most common symptom. Cigarette smoking is a very important risk factor, right? And the commonest type of the motor neuron disease will be amyotrophic lateral sclerosis, where you have involvement of both upper and lower motor neuron involvement, okay? And fasciculations, as I have said you, is the pathognomic of your motor neuron disease. And these patients will have progressive muscle weakness and as well as the atrophy. How will you diagnose? MRI. What it will show you that there is increased signal in corticospinal tract. And these patients, they can develop bulbar palsy, that is due to involvement of 9, 10, 11, 12 cranial nerves, and where there will be difficulty in speaking, drinking, and as well as swallowing. And these patients, cause of death will be respiratory muscle paralysis. There is no specific cure. Riluzole can extend the survival. Edaverone can slow down the disease progression in patients with amyotrophic lateral sclerosis. And overall, these patients, they have poor prognosis, because once they develop bulbar palsy, the survival is only 2 years. And in patients with spinomuscular atrophy, the gene therapy that you can give is onasemnogene abipavovec, and the other alternative therapy will be nusinersen. This is about motor neuron disease, right? Now, yes. Now we'll move on to the next topic. So the next topic for the discussion will be headache, right? The next topic for the discussion will be headache. So what is the most common type of headache among all the forms of headache? So among all the forms of headache, it is the tension headache. Now, coming to the most common type of headache. The most common type of headache will be the tension headache, right? And that is the primary form of headache. Whereas if you take the secondary headache, right? If you take the secondary headache, the most common cause of secondary headache, it is due to infection. Infection is the most common cause of the secondary headache, whereas the most common cause of the primary headache will be migraine, right? Now, if you take this migraine, how do you describe this migraine? These patients with migraine, the headache, we describe it as the episodic headache. And this headache, it is associated with sensitivity to light, where they will have photophobia, sensitivity to sound, and they will also have the associated nausea and as well as vomiting. That will be the features of the migraine. And you can just remember the diagnosis of the migraine by making out this mnemonic. And what is that mnemonic? That mnemonic is POUND. P stands for pulsating in nature. And the duration of headache, it is actually 4 to 72 hours. But on an average, it will be 1 day duration. And U stands for, it is unilateral, N is your nausea, and D stands for disabling in character. That will be the features that you come across in case of migraine. And we have two important forms of migraine. One is classic and as well as the common migraine. Classic migraine is that which is associated with aura. Common migraine is that which is not having any aura. Migraine without aura is nothing but the common migraine. And then we have ophthalmoplegic migraine. Ophthalmoplegic migraine is that along with headache, there is also extraocular muscle weakness where there will be transient third nerve palsy, and due to which they will be having ptosis in case of ophthalmoplegic migraine. And another important form of migraine will be familial hemiplegic migraine, where the individual will have the calcium channel defect. Along with migraine, these patients will also have the contralateral hemiparesis. That will be the familial hemiplegic migraine. So the most common form of primary headache, I'm sorry if I have said you migraine just now, the most common form of primary headache will be tension headache. The most common form of secondary headache will be the infection. Now, that was about the migraine. And what will be the treatment for the migraine that you will give? The treatment that you will give in case of the migraine for acute attack, that will be sumatriptan, right? Acute attack will be sumatriptan. And what is that you give for prophylaxis? For prophylaxis, the drugs that you give is valproate, tricyclic antidepressants, and as well as the beta blockers. And we have one important variant of migraine where the duration of the migraine will be more than 72 hours, and that is called status migrainosus. And that is being treated with prochlorperazine. And what are the other important drugs that we give for these patients with the migraine? We definitely give triptans. And this particular triptans, they act on the 5-HT1B 1D receptors. And there are some contraindications for triptans that includes pregnancy and as well as vasospastic angina. These two are the contraindications for triptans. Now, how will you assess the disease severity in case of the migraine? The disease severity in case of migraine, it is assessed by the MIDAS scoring system. The disease severity in case of migraine, it is assessed by the MIDAS scoring system. Now, what is this particular MIDAS scoring system? It measures the migraine disability impact in the last 3 months, wherein if the individual is having a MIDAS score of more than 21, he should be definitely treated with triptans. And if the individual is having a MIDAS score of less than 20, it is considered as a mild to moderate form of migraine, and that is being treated with the non-steroidal anti-inflammatory drugs have to be given. And how is that you will handle the migraine in pregnancy? In pregnancy, if there is migraine, the individual should be given paracetamol, right? That will be the first line therapy. And there are some new molecules which have come up for the prophylaxis of the migraine. And these new molecules are the CGRP antagonists. And the examples of these CGRP antagonists, they include the following, right? They include the following. That is erinumab. The other one is fremanezumab, then galcanezumab, then the eptinezumab. So these are the new molecules, out of which we have some oral forms and some nasal forms. The oral forms of the CGRP receptor antagonist will be the rimegepant and as well as atogepant, right? And we have nasal CGRP antagonist, that is zevigepant. These are the CGRP antagonists, but please remember they are given for prophylaxis but not for acute attacks of migraine. Now, apart from migraine, what are the other forms of headache? The other forms of headache will be the tension headache. So what is the most common form of primary headache? Tension headache. In case of migraine, it is usually unilateral. But if you take tension headache, it is bilateral. And it is not very severe. This particular tension headache, it is a dull aching pain that is usually associated with stress and as well as depression. Whereas the other important, and this tension headache, it gets relieved by taking rest or just by taking a simple paracetamol. Whereas you take cluster headache. Cluster headache, it is considered as the one where the individual will have a unilateral periorbital pain. It is the one, it is characterized as unilateral periorbital pain. But this particular pain, it is associated with the nasal stuffiness, tearing, and as well as flushing. Nasal stuffiness, tearing, and as well as flushing. That will be the feature of the cluster headache. And this particular cluster headache, it most commonly affects men rather than women. And how do you treat these patients with the cluster headache? Remember, the cluster headache, the first line treatment will be you have to give the high flow oxygen, you need to give 8 to 10 liters of oxygen as a first line treatment. And what is the drug of choice for cluster headache? That will be sumatriptan. And what are the drugs that we give for prophylaxis in case of the cluster headache? It is the same the drugs that we give in case of the migraine, where we give calcium channel blockers and as well as the beta blockers as the prophylaxis in case of the cluster headache. So these are the various forms of, beta blockers, what we give is the propranolol is what we give, and calcium channel blockers, very good, that we give verapamil. So these are the various types of headache. Okay, so this finishes the topic of the headache. Let me just quickly recap the entire headache in just 1 minute. So most common form of primary headache, tension headache. Most common form of secondary headache, that will be infection. If you take the migraine, that is the second most common cause for primary headache. It is usually episodic headache, and you need to remember the mnemonic POUND, pulsating, 1 day duration, unilateral, nausea and disabling in character. You have two forms, classical, which is associated with aura, common without aura. And ophthalmoplegic migraine, along with migraine, you have the extraocular muscle weakness due to third nerve palsy transiently. Familial hemiplegic migraine, it's a calcium channel defect. Along with migraine, you have contralateral hemiparesis. And the treatment in case of migraine, it is completely decided by MIDA score. If the MIDA score is more than 21, it is considered a severe form of migraine where you need to give triptans. And if the MIDA score is less than 20, it is considered as mild to moderate form of migraine where we give NSAIDs. And in acute attack, triptans, and in prophylaxis, we give the beta blockers, tricyclic antidepressants, valproate, and calcium channel blockers. And if the migraine duration is more than 72 hours, we call it as status migrainosus, where we give prochlorperazine. Tension headache, it is usually bilateral, dull aching associated with stress and depression, where we give either paracetamol or simply asking the individual to take rest. Cluster headache, it is usually unilateral, and it's a periorbital pain where there will be nasal stuffiness, tearing, and as well as flushing. And that affects most commonly men rather than women. And the first line treatment will be of the high flow oxygen, and drug of choice will be sumatriptan in case of the cluster headache. Okay, so this finishes the topic of your headache. Done. So all of you are okay with this particular topic of headache now? While any doubt, drug of choice in is no. It is not carbamazepine, Rituraj Sahu. It is sumatriptans. Okay, triptans are considered as drug of choice. Right. So far so good. Chalo. We'll move on to the next topic. What will be the next topic? That is the infections of the CNS. What is that infections of the CNS? That includes meningitis. So if you take this bacterial meningitis, where exactly is the problem? We have three meninges, right? Dura mater is there, arachnoid matter, subarachnoid is there, and then arachnoid layer is there, and as well as the pia mater is there. Okay. Now, out of all these, which particular layer is affected in patients with the meningitis is, it is a purulent infection of the subarachnoid space, which is very important in case of meningitis. Now, the important features in case of meningitis will be, if meningitis spreads to the brain, that we call it as meningoencephalitis. In case of meningoencephalitis, they will have altered sensorium, seizures, raised intracranial pressure, and there can be development of stroke as well. And among all the various organisms causing meningitis, the most common organism will be Streptococcus pneumonia, and apart from that, the other organisms will be Neisseria meningitis, group B Streptococci, and Listeria monocytogenes. But among all these, the most common will be Strep pneumonia. Whereas, if you take the organisms age-wise distribution, in neonates, it is group B Streptococci, Klebsiella, and Listeria monocytogenes. Whereas in children and adults, the most common organism will be Strep pneumonia, that is nothing but pneumococcus. And what exactly is the pathophysiology in these patients? Usually there is an inflammatory reaction in these meninges, right? And that is mainly in the arachnoid layer, where there will be purulent exudate that gets affected in the subarachnoid space. And the classical clinical picture in patients with meningitis will be in the form of a triad. Because it's an infectious pathology, they will have high-grade fever. And because it's a CNS-associated problem, they'll have severe headache. And there will be nuchal rigidity. So fever, headache, nuchal rigidity, that is a triad in patients with case of meningitis. Whenever there is meningoencephalitis, there will be decreased consciousness in the individual. And because of raised intracranial pressure, they will have papilledema and as well as photophobia as well, right? And there is one particular organism which will be causing post-meningitis deafness. What is that organism? That is Haemophilus influenza. That's an important multiple choice question. Now, whenever you are doing a workup in patients with meningitis, what is the sequence that you need to follow? Right? The sequence can be asked as a question. You need to remember the sequence. First and foremost, you need to draw the blood culture whenever you are suspecting meningitis. Then immediately give, after drawing the blood culture, give empirical antibiotics like ceftriaxone. Then you need to perform neuroimaging in order to look for any presence of intracranial space occupying lesion. And if there is any intracranial space occupying lesion, or if there is raised intracranial pressure, lumbar puncture should not be done. And if raised intracranial pressure is not there, then you need to do the lumbar puncture. Okay. And if there is no raised intracranial pressure, right? I'm repeating my word. If there is no raised intracranial pressure, then you need to do lumbar puncture. But if there is presence of raised intracranial pressure, if you do lumbar puncture, these patients can develop cerebral herniation, which will be a very problematic scenario in the individual. Now, whenever you are doing lumbar puncture, it should be done in the L3 and L4 space. And what is the needle that we use? The needle that we use is nothing but Quincke's needle, or we call it as the Sprott's needle. And whenever you are inserting the needle, the needle should be inserted at 10 degrees cephalad direction. And how should be the bevel? The bevel should be facing upwards. And there are some contraindications for lumbar puncture. And what are these contraindications? That includes raised intracranial tension, bleeding manifestation, local site infection, and as well as the spine deformities in the form of kyphoscoliosis, right? And what are the common complications that you come across in patients with meningitis is the hydrocephalus, right? And why is this particular hydrocephalus? That is due to impaired absorption of the CSF in the subarachnoid space, and that is due to subarachnoid granulations. Whenever there is meningoencephalitis, there can be development of stroke, cranial nerve palsy can be there, seizures can be there, and as well as the encephalitis can be there. Now, if you take the individual organisms, that is tubercular meningitis is very common in case of immunocompromised individuals like the HIV. And in patients with the tubercular meningitis, you need to be very much aware of the basal meningitis. So in order to avoid, or in order to treat the basal meningitis, you need to give corticosteroids in patients with tubercular meningitis before giving anti-tubercular therapy. And how will you diagnose tubercular meningitis? By doing the CSF culture. And another important meningitis is caused by the virus. The most common virus will be the enterovirus. And in case of the enterovirus, how will you diagnose? You will have the presence of the lymphocytic pleocytosis. In bacterial meningitis, it is neutrophilic predominant. Whereas in tubercular meningitis, viral meningitis, fungal meningitis, it is lymphocytic predominant. And how do you treat these patients? In case of bacterial meningitis, you need to give ceftriaxone and as well as vancomycin as an empirical therapy. But please remember, whenever you are giving ceftriaxone, you need to give 2 grams IV. It is not 1 gram. Why? Because in case of the tubercular meningitis, in case of bacterial meningitis, if you want to ensure that the ceftriaxone has to cross the blood-brain barrier, you need to give 2 grams. 1 gram of ceftriaxone will not cross the blood-brain barrier. And if you take the cryptococcal meningitis, cryptococcal meningitis is also very common in case of the HIV infected individuals, which is a fungal form of meningitis. How will you diagnose this cryptococcal meningitis? That is by Indiaing staining of the CSF analysis, and treatment should be done by the amphotericin B and as well as the flucytosine. These are the 2 important molecules that we give for cryptococcal meningitis. And always I have said you, in case of tubercular meningitis, you need to give corticosteroids, that is dexamethasone, before giving the antibiotics. Either you take in bacterial meningitis or tubercular meningitis, you need to give dexamethasone before antibiotics. Why is that? That is mainly to prevent the basal meningitis. Now, what is very, very important part of the discussion in the meningitis, that is the CSF analysis. And if you take the normal CSF pressure, it is 50 to 180 millimeters of water, and the CSF will be absolutely clear like water, and the number of cells will be 0 to 5 cells per cubic millimeter, and that too, it is lymphocytes more than compared to that of the neutrophils. And sugars, if you see, it is like 2/3 of the blood glucose will be the glucose in the CSF. And how much will be the proteins in the CSF? That is 15 to 45 milligrams percentage. That will be the proteins in the CSF. Whereas you take in case of the bacterial meningitis, in all the forms of meningitis, the CSF pressure will be elevated. Either bacterial, tubercular, viral, and as well as fungal meningitis, the CSF pressure will be normal. Whereas in Guillain-Barre syndrome, the CSF pressure will be normal. Whereas in all other conditions, the CSF pressure is increased in the infectious pathologies. And if you take the color of the CSF, in acute bacterial meningitis, it will be turbid. Whereas in case of tubercular meningitis, it will be like straw colored, right? Whereas in viral meningitis and in all other forms, it will be like clear, right? It will be like clear, right? And if you take the cells in tubercular meningitis, it is mainly neutrophilic predominant. Whereas in the tubercular meningitis, bacterial meningitis, it is neutrophilic predominant. Whereas in tubercular meningitis, lymphocytic predominant. Whereas viral meningitis, lymphocytic predominant. Fungal meningitis, lymphocytic predominant. And will there be increase in the number of cells in Guillain-Barre syndrome? No. The number of cells will be normal. And what will happen to the glucose levels in all these meningitis? The inflammatory cells, they will utilize the glucose, or the organisms, they will utilize the glucose. So bacterial meningitis, glucose reduced. Tubercular meningitis, glucose reduced. And in viral meningitis, it is more or less normal. In Guillain-Barre syndrome, it is more or less normal. Whereas in fungal meningitis, the glucose will be utilized, so the glucose levels will be low. And in all the forms of meningitis, antibodies are formed against the organisms. And what are these antibodies? They are nothing but proteins. So that is the reason why the CSF proteins, they are elevated in all the types of meningitis, including Guillain-Barre syndrome. Guillain-Barre syndrome, you have albuminocytological dissociation. So I'm telling you, please revise this table before you go to the exams. Before you going to the exams, you have to definitely revise this particular table, without which there is a high scope that you will miss this question on the CSF analysis of the meningitis. Okay, right. So that finishes the topic related to meningitis. So in 1 minute, I'll quickly recap the entire meningitis. Then we will move on to the next important infection within the CNS. So meningitis, basically, what is the problem? It's a purulent infection in the subarachnoid space. Common organisms, Streptococcus pneumonia. In children, it is group B streptococci, Klebsiella, Listeria monocytogenes. Whereas in children and adults, pneumococci. And the triad in these individuals will be fever, headache, and as well as nuchal rigidity. Post-meningitis deafness caused by Haemophilus influenza. And what is the sequence in the workup? You need to draw the blood culture, give an empirical antibiotic, perform the neuroimaging, and perform lumbar puncture if there is no raised intracranial pressure. And where is the site that you will do lumbar puncture? Between L3 and L4. What is the needle? Quincke's needle or Sprott's needle, right? And contraindications for lumbar puncture: raised intracranial pressure, bleeding manifestations, local site infection, spine abnormalities. And the common complication in case of meningitis will be the hydrocephalus, right? And in case of the tubercular meningitis, basal meningitis is very common. So that is the reason why you need to give dexamethasone, followed by that anti-tubercular therapy should be given. Viral meningitis, the most common virus will be enterovirus, where you will have lymphocytic pleocytosis. And whenever you are treating bacterial meningitis, you need to give 2 grams of ceftriaxone and as well as vancomycin. But before giving this ceftriaxone and vancomycin, you need to give dexamethasone. Whereas in cryptococcal meningitis, which is very common in HIV-infected individuals, they also have lymphocytic pleocytosis, and the diagnosis is done by India Ink stain. Treatment is done with amphotericin B and as well as the flucytosine. Okay, so this is about meningitis, right? So any questions on meningitis? Yeah, yes, Shanawaz, you will have the, neck stiffness will be there, and you will have the Brudzinski sign, right? And you have the passive leg raising, you will have stiffness or pain in the lower back. Brudzinski's neck sign will be there. That will be positive. Right. Now, we'll move on to the next topic for the discussion, that is neurocysticercosis. Okay. So if you take this particular cysticercosis, it is the tissue infection which is caused by the larval cyst of the Taenia solium, right? And how does the individual acquire this? By ingesting the food which is contaminated with the Taenia solium eggs. And very common in Mexico and Central and South America. Now, okay, and multiple places you have the presence of the cysts, but commonly the cysts are present in the brain parenchyma. That is the most common location of the intracranial neurocysticercosis. And what are the other organs affected where you have the presence of the cysts? That is subcutaneous tissue, striated muscle, and as well as the globe of the eye. Accordingly, you have the clinical features. If brain you have the cysts, these patients will have like headache, hydrocephalus, and seizures. And if the muscle is having the cyst, the individual will have muscle discomfort. If the cyst is present within the eye muscles, that can result in ptosis and as well as the intraocular abnormalities. And how will you diagnose? Because it's a parasitic infection, when you do a CSF analysis, that will show you eosinophilic pleocytosis. And even the inflammatory cells which are there, that will utilize the CSF glucose, and thereby there will be decreased CSF glucose. And antibodies are formed against this particular larva, which is nothing but proteins. There will be elevated proteins that you will have. And serology should be done, that is mainly for the diagnosis. And when you do the CT or MRI, the CT or MRI will show you that there is multiple parenchymal cysts, and that will give you a starry sky appearance. And how do you treat these patients with the neurocysticercosis? You need to give the albendazole, that is a drug of choice, and the alternative drug will be praziquantel. Alternative drug will be praziquantel. And in almost all the CNS infections, you need to give glucocorticoids first. That will reduce the inflammation, and that should be followed by supplementing this albendazole, or the praziquantel should be given. Okay, but there are some contraindications for the treatment. So what are the contraindications? That is, in individuals with hydrocephalus, the cysticidal therapy should be avoided, right? Mainly whenever there is subarachnoid involvement, cysticidal therapy should be avoided, because this, whenever you are giving cysticidal therapy, that will break this particular cyst, that will initiate the inflammatory reaction, and that will cause more and more subarachnoid granulations, and wherein the hydrocephalus will get precipitated. So the diagnostic tools are mainly the neuroimaging, where you have starry sky appearance, CSF analysis, which will show you eosinophilic pleocytosis, and serological test, that by ELISA you will be able to make out the presence of this Taenia solium larva. Okay, so this is about neurocysticercosis. So in just 1 minute, I will just give you a quick review of the neurocysticercosis. So it's a tissue infection caused by larval cyst of Taenia solium, right? And how is it being acquired? That is ingestion of the contaminated food, which is very common in Mexico. The commonest location will be brain parenchyma. The other areas which gets affected will be subcutaneous tissue, striated muscle, and globe of the eye. And in the brain, if there are cysts, there will be development of seizures, headache, and hydrocephalus. Muscle discomfort can be there. Eye involvement will cause the ptosis. CSF analysis will show you eosinophilic pleocytosis. The imaging will show you the CT or MRI, if it is being done, that will show you a starry sky appearance. The preferred treatment will be the albendazole, and the alternative treatment will be the praziquantel. And contraindications for treatment will be hydrocephalus. If it is there, then you should not give cysticidal therapies. Okay, so that was about the story related to infections of the central nervous system. Very commonly asked questions will be like meningitis, and there were also questions on the treatment of neurocysticercosis in the previous year questions. Okay, with this we are done. And so let me just quickly ask you the starry sky appearance. Yeah, so please tell me, where is that you'll have starry sky appearance in the lymph node biopsy? Lymph node biopsy showing starry sky appearance. Ultrasound abdomen showing starry sky appearance. Ultrasound abdomen showing starry sky appearance, that will be observed in acute viral hepatitis. That is mainly in hepatitis B infection. Okay, next, followed by this, you need to be completely aware of what is the condition where you will have starry sky appearance on renal biopsy. Done. Now, after having discussed about the infections of the CNS, let us discuss some spinal cord disorders. And among the spinal cord disorders, very important is the Brown-Sequard syndrome. What exactly is your Brown-Sequard syndrome? It is the hemisection of the spinal cord. It is the hemisection of the spinal cord. And because of the hemisection of the spinal cord, these patients, they will have the ipsilateral and as well as the contralateral neurological deficit. Okay, now what will be that? Please remember, at the level of lesion, the ipsilateral features will be flaccid paralysis, because at the level of lesion, your lower motor neuron involvement will be there, that is anterior horn cell. So there will be flaccid paralysis. Below the level of lesion, okay, let me finish at the level of lesion, and then we'll move on to below the level of lesion. Now, so ipsilateral features will be like flaccid paralysis. Then what will be the contralateral? Contralateral, please remember, there is no motor changes. Contralateral, there is no motor changes, at the level of lesion. But below the level of lesion, yeah, very good, Shainavas. Right. Below the level of lesion, there will be loss of proprioception. Basically, you will have ipsilateral dorsal column sensations lost, right? Whereas contralateral spinothalamic tract sensations are lost, right? So ipsilateral dorsal column sensations are lost and contralateral spinothalamic tract sensations are being lost, right? And below the level of lesion, due to the involvement of the corticospinal tract, these patients will have spastic paralysis due to the involvement of corticospinal tract, right? And below the level of lesion, what will be the contralateral features? I said you already. There will be contralateral spinothalamic tract sensations are being lost. So to summarize now, at the level of lesion, ipsilaterally, motor manifestation will be flaccid paralysis. Contralateral, there is no motor manifestation at the level of lesion. Coming to below the level of lesion. Below the level of lesion, motor manifestations will be spastic paralysis due to corticospinal tract involvement. What is the sensory features below the level of lesion? Below the level of lesion, ipsilateral dorsal column sensations are lost. Contralateral spinothalamic tract sensations are being lost. Okay, that is what you observed in patients with the Brown-Sequard syndrome. Now, how do you manage these patients? So the treatment that you need to give in these patients is the surgical treatment, if at all, if you want to do, surgical treatment will be ventrolateral cordotomy, right? Pain management technique will be ventrolateral cordotomy. Ventrolateral cordotomy, if you do, it interrupts the contralateral lateral spinothalamic tract. Okay, fine. Before doing that ventrolateral cordotomy, what is a conservative treatment that you need to do? Immobilization is the first important thing that you need to do in the patients who are having this hemisection of the spinal cord. Followed by that, immediately, as soon as possible, you need to give high-dose corticosteroids, right? High-dose corticosteroids. And if it is started early, there can be improvement in the neurological deficit. And within 24 hours, you try to do decompressive laminectomy so that the compressive manifestations will get recovered. So that is about the Brown-Sequard syndrome. So in 1 minute, let me finish the Brown-Sequard syndrome. What exactly is this? It's a hemisection of the spinal cord. You have the clinical features at the level of lesion, below the level of lesion. At the level of lesion, ipsilaterally, flaccid paralysis. Contralateral, no motor deficit. Below the level of lesion, ipsilaterally, you will have the spastic paralysis due to corticospinal tract involvement. What are the sensory manifestations? Ipsilateral dorsal columns, contralateral spinothalamic tract sensations are being lost. Treatment, immobilization is the first important thing that you need to do. Give methylprednisolone as soon as possible. Within 24 hours, try to do decompressive laminectomy. That is about your Brown-Sequard syndrome. Done? Now, we'll move on to the next important spinal cord disorder, that is your conus medullaris and as well as the cauda equina. So you take this conus medullaris and as well as cauda equina. What exactly is the basic anatomy of this? If you take the conus medullaris, it is the distal end of the spinal cord. Whichever is there is called conus medullaris. And what does this conus medullaris constitute? It is a sacral spinal cord. It's a sacral spinal cord. That is S1 to S5, and that is located at L1 to L2. It is actually sacral, but it is located at the lumbar level. But what is cauda equina? Cauda equina is the collection of nerve roots. Which particular nerve roots are there in cauda equina? You will have lumbar and as well as sacral. These two together, they constitute the cauda equina. Now, in case of the conus medullaris, it includes both upper motor neuron and as well as lower motor neuron. Whereas cauda equina, it is purely lower motor neuron involvement only. So, if you take the motor symptoms, in case of the conus medullaris, it is bilateral symmetrical weakness. Whereas in cauda equina, it is asymmetrical weakness. It is not symmetrical, it is asymmetrical weakness. That will be the motor involvement. And in case of the conus medullaris, it is only sacral part of the spinal cord which gets affected. So ankle jerk is lost, but knee jerk is preserved. Whereas in Cauda equina, both knee jerk and ankle jerk, both of them are absent. Now, what will be the sensory symptoms in patients with conus medullaris? They will have saddle anesthesia. Whereas in Cauda equina, you will have unilateral saddle anesthesia. It is not bilateral, unilateral saddle anesthesia will be there. And will there be pain? Yes. Radicular pain will be there in case of the Cauda equina rather than the conus medullaris. Right? Radicular pain will be there in case of Cauda equina rather than the conus medullaris. And will there be bowel and bladder involvement? Yes. Bowel and bladder involvement will be early and prominent in case of conus medullaris because there is involvement of the sacral part of the spinal cord. And that bowel and bladder involvement can be either in the form of retention or incontinence. Whereas in Cauda equina, it is the spinal nerves which are getting affected here, and that too, right? Yeah, and that too, the initial fibers which gets affected will be lumbar fibers, and that is the reason why you will have the involvement of the bladder and bowel later, because the sacral spinal nerves gets affected later in case of Cauda equina. So early and prominent involvement in conus medullaris, late involvement in case of the Cauda equina. And what did I tell you about the reflexes? In case of conus, the knee jerk is preserved, ankle jerk is absent. Whereas in Cauda equina, both the reflexes are being lost. And if you take the laterality of the symptoms, what did I tell you? In conus, it is usually symmetrical, bilateral. Whereas asymmetrical is what you observe in case of the Cauda equina. And what will be the clinical features? There will be weakness in the lower extremities in case of the conus, right? Whereas flaccid paralysis is observed in case of the Cauda equina because it is the lower motor neuron which is being affected. And radicular pain is very severe in case of Cauda equina rather than the conus medullaris. And how do you treat these patients? In case of the conus medullaris, pain control should be done with the NSAIDs or the steroids. And these patients, they have to be done surgical decompression for bladder bowel symptoms. Surgical decompression should be done. Whereas in case of Cauda equina, you need to do emergency decompression. That is the mainstay of treatment in case of the Cauda equina as well. So in both of them, surgical decompression, it plays a very, very important role in the treatment. Okay. So this is about your conus medullaris and as well as Cauda equina. So in the clinical scenario, how is that you will be able to differentiate both of these is symmetry. Conus medullaris, symmetrical. Cauda equina, asymmetrical. Conus medullaris, only knee jerk lost. Sorry, in conus medullaris, only ankle jerk lost, knee jerk preserved. Whereas Cauda equina, both knee and as well as ankle jerks, both are lost. Radicular pain, Cauda equina. Saddle anesthesia, conus medullaris, right? And early bladder involvement, conus. Late bladder involvement, Cauda equina, right? Pain, very common in Cauda equina rather than conus medullaris, okay? So these, and in both of them, the treatment is the decompression. And for pain, you need to give NSAIDs. Okay. So this is about the conus medullaris and Cauda equina, which is another important spinal cord disorder. Next, we'll move on to the next topic, that is syringomyelia. Okay. So what is syringomyelia? It is the one where the individual will have a dissociative anesthesia. Right, where the individual will have a dissociative anesthesia. That is what is called the syringomyelia. Okay. Now, what is the problem in patients with the syringomyelia is that where you have the formation of a cavity within the central part of the spinal cord. So now let us discuss syringomyelia, where you have the cavitation in the central part of the spinal cord. Now, this syringomyelia, it is commonly associated with Budd-Chiari syndrome type 1, right? And I'm sorry, not Budd-Chiari. So it is Arnold-Chiari malformation type 1. And not only Arnold-Chiari malformation type 1 is having the development of syringomyelia, even the Arnold-Chiari type 2 malformation also have, but that is commonly associated with cerebellar tonsils. So it is Arnold-Chiari type 1. So what is the problem? It is the cavitation in the spinal cord. Which part of the spinal cord? That is, in the cervical region, the cavitation is very common in patients with the syringomyelia. And there will be dissociative anesthesia. What is the dissociative anesthesia? There will be loss of spinothalamic tract sensations. There will be loss of pain and temperature sensations, but there will be preserved dorsal column sensations. So there will be sparing of touch, proprioception, and as well as the vibration. That will be the hallmark in case of syringomyelia. So the description in the clinical scenario that they will be giving is painless burn. Why there is painless burn? Because there is damage to spinothalamic tract, because of which the individual will not be able to feel the temperature and as well as pain. And not only that, when this syringomyelia or cavitation extends onto the corticospinal tract, there can be wasting of the small muscles, there can be spasticity of the legs and as well as exaggerated deep tendon reflexes, there can be bladder and bowel dysfunction. And because the pain sensation is being lost, they will have the Charcot's joints and as well as the trophic ulcers. And what are the complications that you commonly across in syringomyelia is, if this cavity extends upwards from the cervical region into the brainstem, that will result in syringobulbia, where you have the involvement of the cranial nerves 9, 10, and as well as 12. And due to which the presentation will be in the form of difficulty in articulation of the speech because your 9th and 10th is gone. Nystagmus will be there, vertigo, tongue weakness due to the involvement of the 12th cranial nerves. And how will you diagnose this syringomyelia? Gold standard investigation will be the MRI. MRI is the one which will detect the presence of the syrinx and if there is any associated spinal cord changes. And how will you treat these patients? Whatever that cavity is there, that particular cavity has to be removed, or you need to ensure that the cavity is not compressing the spinothalamic tract, for which you need to do surgical decompression. And whenever you are doing surgical decompression, what is the approach that you need to follow? The approach that you need to follow is suboccipital craniectomy, and cervical laminectomy should be done in case of the Arnold-Chiari malformation where there is presence of the syringomyelia. And there is a characteristic sign in patients with syringomyelia that is called Lermit sign or Barber-Chair sign, which we have also discussed this in case of multiple sclerosis. So Barber-Chair sign or Lermit sign is that where there will be electric shock-like sensations on flexing the neck. Down the spinal cord, you have electric shock-like sensation. So this Barber-Chair sign or Lermit sign is not present only in case of syringomyelia and multiple sclerosis. It is also observed in case of vitamin B12 deficiency also, that is subacute combined degeneration of spinal cord. And it is also present in patients with cervical spondylosis as well. So these are all differential diagnoses for Lermit sign. Multiple sclerosis, syringomyelia, subacute combined degeneration of spinal cord, and as well as cervical spondylosis. Okay, so this finishes the topic of the syringomyelia. So in 1 minute, I'll revise the entire syringomyelia. What exactly is this? Cavitation of the central part of the spinal cord, most commonly associated with Arnold-Chiari malformation type 1. And which part of the spinal cord? It is mainly the cervical region. And the hallmark feature will be dissociative anesthesia. The characteristic description in the clinical scenario that will be given is the painless burns. And due to the involvement of the corticospinal tract, as the cavity expands laterally, there can be wasting of the small muscles and there will be spasticity of the legs and exaggerated deep tendon reflexes. Complications will be syringobulbia. Investigation of choice will be MRI. Treatment of choice will be surgical decompression, that is by suboccipital craniectomy and cervical laminectomy. Okay, and very important signs that you need to remember is Lermit sign or Barber-Chair sign. Done. So this is about the syringomyelia. Now, next important topic will be the autonomic neuropathy. So with this, we have done with the spinal cord disorders. What are those? Syringomyelia is one spinal cord disorder. Next is Conus medullaris and Cauda equina. Next is Brown-Sequard syndrome, where you have hemisection of the spinal cord. Okay, now we'll move on to the next topic, that is the autonomic neuropathy. So in case of autonomic neuropathy, you have the two important systems which gets affected very, very badly. What are those two important systems? That is sympathetic and as well as the parasympathetic nervous system. And what is this parasympathetic nervous system? That is craniosacral outflow. Whereas sympathetic nervous system, it is thoracolumbar outflow, that is T1 to L2. And characteristic clinical manifestation will be orthostatic hypotension. And what is the criteria to call it as orthostatic hypotension? Where the systolic blood pressure will fall by more than 20 and diastolic blood pressure will fall by more than 10. And please remember, it is not mandatory that both systolic and diastolic should fall down. Either of this, either systolic drops down or diastolic drops down, we call it as orthostatic hypotension. And these patients, due to orthostatic hypotension, they will have syncopal attack. And due to the involvement of sympathetic and parasympathetic nervous system, there will be altered sweating in these patients. Yeah, yes, it is after 3 minutes of standing. It is after 3 minutes of standing. And gastrointestinal issues will be in the form of either constipation or diarrhea. It all depends upon whether sympathetic or parasympathetic is being affected. And these patients will also have the impotency. So gastrointestinal symptoms will be what? That includes like gastroparesis, constipation, diarrhea, nausea, and vomiting, right? And bladder abnormalities are also very common. And what will be that bladder abnormalities? Either there will be incomplete emptying or the urinary incontinence. It all depends upon parasympathetic or sympathetic being affected. And cardiovascular manifestation, as I was saying you, orthostatic hypotension is very, very important. And genitourinary abnormality will be in the form of erectile dysfunction, for which you need to give phosphodiesterase inhibitors like sildenafil, tadalafil, and as well as vardenafil. And how will you do the workup of these patients? MRI is what you need to do in order to look for structural abnormalities damaging the parasympathetic or sympathetic nervous system, right? And the treatment, it all completely depends upon what is the abnormality. If it is orthostatic hypotension, drug of choice will be alpha-1 agonist, that is midodrine, or alternative drug will be fludrocortisone. And if there is gastroparesis, you need to give prokinetic drugs like metoclopramide. And erectile dysfunction is being treated by phosphodiesterase 5 inhibitors, that is sildenafil or the tadalafil or the vardenafil has to be given, right? And the complications associated with metoclopramide will be tardive dyskinesia. That is a long-term complication associated with metoclopramide, right? And the another important long-term complication with phosphodiesterase 5 inhibitors will be priapism, or there can be development of the hypotension as well. That is the reason why you should never combine phosphodiesterase inhibitors with the nitrates. If you combine phosphodiesterase inhibitors with nitrates, there can be significant hypotension and there will be cardiovascular collapse in this individual. Okay. And another very important problem with the phosphodiesterase inhibitors is the visual loss. That is being reported with phosphodiesterase inhibitors, but that is a rare complication of phosphodiesterase inhibitors. Okay. So this is about your story related to the autonomic neuropathy. Right. So let me just quickly recap autonomic neuropathy in 1 minute. So what is autonomic neuropathy? Damage to either sympathetic or parasympathetic nervous system. What will be the classical manifestations? Orthostatic hypotension, syncopal attack, and there will be altered sweating, either hyperhidrosis or hypohidrosis. Gastrointestinal manifestation will be in the form of gastroparesis, constipation, or diarrhea. Bladder abnormalities will be in the form of urinary incontinence, or there can be increased frequency and hesitancy. Erectile dysfunction, that will be the genitourinary abnormalities. Investigations, you need to do MRI. And orthostatic hypotension, the treatment is done by either fludrocortisone or midodrine. Gastroparesis, you need to give metoclopramide, that is prokinetic drug. Erectile dysfunction should be treated with phosphodiesterase inhibitors. And the long-term complications of your metoclopramide will be tardive dyskinesia, and phosphodiesterase inhibitors should never be combined with nitrates. If you combine, the individual can develop priapism, or there can be development of the hypotension. Okay. So this is about the autonomic neuropathy. Done? Now we'll move on to, let me finish this neurology. Ritraj Sahu, let me finish this neurology. Yeah. Now the next, because once this neurology, if we give a break now, that will be an interruption. Let me finish this. Hardly you have another 4 or 5 topics in the neurology will be done. Coming to the next important topic, that is Parkinsonism. So what exactly is the problem in Parkinsonism? It is the loss of dopamine in the substantia nigra, and due to which the individual will have the motor and as well as the non-motor symptoms. And we have 3 important forms of Parkinsonism: primary, secondary, and as well as atypical. Primary Parkinsonism, it is idiopathic and it is mainly due to genetic gene abnormality. Secondary Parkinsonism, the most common cause for secondary Parkinsonism will be drug-induced, and the most common drug will be antipsychotics, that is haloperidol, and the other drugs will be antiemetic. We also have some toxins which can cause Parkinsonism, that is manganese and as well as carbon monoxide. And structural lesions causing Parkinsonism will be stroke and as well as tumors. Infections causing Parkinsonism will be viral encephalitis and as well as the HIV. Then, what is this atypical Parkinsonism? Always remember, atypical Parkinsonism is nothing but Parkinson's plus. Usually, patients with atypical Parkinsonism, they have the autonomic manifestations. That is very important to call it as atypical Parkinsonism. And what are those? That is progressive supranuclear palsy, multiple system atrophy, corticobasal degeneration, and dementia with Lewy body. These are your atypical Parkinsonisms, right? Now, what exactly is the pathophysiology in case of primary Parkinsonism? Dopaminergic neuronal loss, where in the substantia nigra, so dopamine levels will be reduced, and you have the formation of the inclusion bodies, and these inclusion bodies will be Lewy bodies, whereas in Alzheimer's you have the Hirano bodies, and these patients, they will have the cardinal manifestation as resting tremors. But if the question is asked to you, what is the earliest manifestation in Parkinsonism? Can anyone tell me what is the earliest manifestation in Parkinsonism? Atonia, not atonia. Earliest manifestation in Parkinsonism will be anosmia. Earliest manifestation in Parkinsonism will be constipation. That will be the earliest manifestations. Followed by that, if the question is asked to you, what is the earliest manifestation? Now, falling down is not early. Falling down will be late manifestation. Okay. Right. Okay. So, the earliest motor manifestation will be resting tremors. Earliest motor manifestation will be in the form of the resting tremors. Okay. And that too, it will be in the form of the pill rolling tremors. And slowness of the movement, that is called bradykinesia. Rigidity, that will, so in upper limbs, you have cogwheel rigidity. And in the lower limbs, you have the lead pipe rigidity. And they will have postural instability. And whenever there is postural instability, they will be having this falling down. But the postural instability is not the earliest manifestation. And what is the characteristic gait? The characteristic gait that we describe in these individuals will be festinate gait. That will be festinate gait. Non-motor manifestations will be in the form of anosmia and constipation, which are very early. And these patients will have the sleep disturbances, right? That is REM behavior abnormalities or disorder can be there. And mood disorders, like where they will have depression and as well as anxiety. And in late stages, they will be having cognitive impairment. So this will be non-motor manifestations. But the earliest motor manifestations will be like the anosmia and as well as the constipation. And how will you diagnose these patients? So diagnosis in these individuals, it is done by like PET or SPECT. Actually, majority of the individuals, we diagnose it clinically. But if you want the, the definitive diagnosis, right, where you want to have a documented evidence, then you need to do a PET or SPECT that will show you that there is reduced dopaminergic uptake in the substantia nigra or your striatum, right? And MRI is being done mainly to rule out the secondary causes for Parkinsonism, that is vascular or the structural lesions. And what is the mainstay of treatment? Mainstay of treatment for motor manifestations will be levodopa plus carbidopa. And what are the other examples? We have dopamine agonists, and these dopamine agonists include pramipexole and ropinirole, COMT inhibitors, that is entacapone and tolcapone, and monoamino oxidase inhibitors like selegiline and as well as resegiline. And in refractory cases, you need to do deep brain stimulation, right? And whenever you are doing this deep brain stimulation, you need to target the subthalamic nucleus or the globus pallidus interna. Why? Because your substantia nigra is damaged. So there is no point in placing the electrode in the substantia nigra. So you have to place the electrode either in the globus pallidus interna or in the subthalamic nucleus, right? Now, you have drug-induced Parkinsonism, which is the most common form of Parkinsonism, which is caused by the haloperidol. So common drugs include haloperidol and as well as metoclopramide. And in these patients with drug-induced Parkinsonism, the clinical manifestation will be rapid in onset and the tremors are less common. So the treatment that you need to give is you need to discontinue whatever is the drug that is causing Parkinsonism. And for drug-induced Parkinsonism, the drugs that we give is the benzhexol or trihexyphenidyl is what you need to give. And whenever you are giving this levodopa, what are the complications? That will be dyskinesia. That will be the most common complication with the levodopa induced, right? And it is not most common. Actually, the most common will be like nausea and vomiting. One of the very important complications for levodopa induced will be dyskinesia. And whenever you suddenly stop the levodopa, Abrupt withdrawal will result in the development of neuroleptic malignant syndrome. And in the late stages, what did I tell you? There will be development of dementia and as well as cognitive decline in late stages of Parkinsonism. Okay, so this is about the Parkinsonism, but let me just quickly tell you, yeah, biperidine, benzoxazole, and as well as the trihexyphenidyl. These are all the drugs given for drug-induced Parkinsonism. Biperidine is also the drug which is given for drug-induced Parkinsonism. Okay. Now after having discussed about the typical Parkinsonism, let me discuss the atypical Parkinsonism. So what are the various forms that we have discussed? Progressive supranuclear palsy, multiple system atrophy, corticobasal degeneration, and dementia with Lewy body. Let me discuss the 4 important atypical Parkinsonisms, right? Number 1, the progressive supranuclear palsy. These patients with progressive supranuclear palsy, one of the very, very important manifestation that will be vertical gaze palsy, and that is the reason why these patients will have recurrent falls. And that vertical gaze palsy is due to damage to the superior colliculus. And other features of Parkinsonism like bradykinesia, rigidity. Whenever you do an EOG, the electrooculography, you will have the presence of square wave jerks. And MRI will show you the presence of the hummingbird sign. And what is the treatment that you need to give is, whenever you give levodopa, they will have limited response. Along with levodopa, you need to add the other dopamine agonist as well. And along with that, physiotherapy is very important. That is, physical and occupational therapy is very important. So progressive supranuclear palsy, immediately what is that should strike your brain? That is superior collicular involvement causing vertical gaze palsy, hummingbird sign, square wave jerks. These are the things that should strike your brain. Coming to multiple system atrophy. Multiple system atrophy, we have a very important variant that is called MSAC, that is cerebellar involvement, right? Where there will be having cerebellar ataxia. And these patients, they will have autonomic insufficiency and they will have all other features of Parkinsonism. What did I tell you? Atypical Parkinsonism means you have autonomic involvement. And see, there we were describing it as a hummingbird sign for progressive supranuclear palsy. For multiple system atrophy, it is hot cross bun sign. And with levodopa, is there any good response? No, poor response. But because there is autonomic insufficiency causing orthostatic hypotension, you need to give fludrocortisone or the midodrine should be given. Next important subtype is corticobasal degeneration. So in corticobasal degeneration, the characteristic finding will be alien hand syndrome. Apart from this, the asymmetrical rigidity, apraxia, and as well as aphasia will be there. And if you do an MRI in patients with corticobulbar degeneration, it will show you that there is damage to the corpus callosum. And will there be any improvement with dopamine agonist? Moderate improvement will be there in patients with the corticobasal degeneration. And what is the last important form of your atypical Parkinsonism? That is dementia with Lewy body. Dementia with Lewy body, the characteristic finding will be the cognitive impairment. Okay, so cognitive impairment will be there before the onset of the features of the Parkinsonism. And these patients will also have the visual hallucinations and fluctuating attention will be there. And when you do an MRI, that will show you a generalized atrophy of the brain, and levodopa is the one which is given for the motor symptoms. For cognitive impairment, you need to give rivastigmine. You should avoid antipsychotics in these patients with dementia with Lewy body. And we have one more important form of dementia that is called frontotemporal dementia. It is not your atypical Parkinsonism, but I'm just discussing this as a part of the dementia. So if you take this frontotemporal dementia, these patients, you have the involvement of the frontal and temporal lobe, due to which they will have behavioral and as well as the personality changes. Language disturbance will be there. And you have the involvement of the frontotemporal region. Memory deterioration can be there. And MRI finding, you will have the panda face sign, right? Or face of panda sign. Then the treatment will be symptomatic management and behavioral language changes has to be given. There is no specific cure for these patients with the frontotemporal dementia. Okay. So these are about the atypical Parkinsonism. Done? So yeah, the abnormality that you will have is the hexanucleotide repeat. These conditions, they don't fall completely under tauopathies. Under tauopathy, what will fall is your frontotemporal dementia. Now we'll move on. Yes, we'll move on to the next topic for the discussion, that is the epilepsy. Okay, before that, 1 minute, the entire Parkinsonism. Okay, right. So if you take this Parkinsonism, The problem is in the substantia nigra, dopamine reduced. So three forms: primary, secondary, and atypical Parkinsonism. Primary, gene abnormality. Secondary, most common, drug-induced. That too mainly haloperidol. Toxins, manganese, and carbon monoxide. Right? Atypical Parkinsonism, Parkinson's plus, which is nothing but autonomic manifestations will be there. And in case of pathophysiology, you have the formation of the inclusion bodies, that is Lewy body, in the substantia nigra. Earliest manifestation will be anosmia and constipation. Earliest motor manifestation will be resting tremors, that is pill rolling tremors, and that too asymmetrical. Bradykinesia, cogwheel rigidity in upper limbs, lead pipe rigidity in the lower limbs. Postural instability will be there in the later part of the Parkinsonism, and these patients, the characteristic gait will be festinate gait. Okay. And these patients, the investigations that you need to do is PET or SPECT, that will show you reduced dopaminergic uptake in the striatum. And treatment will be levodopa plus carbidopa. Surgical options will be deep brain stimulation, and that too in the refractory cases. In drug-induced Parkinsonism, common drug will be haloperidol. Bilateral rapid onset tremors will be there. And complications that you come across in these patients who are taking levodopa will be dyskinesia, and abrupt withdrawal of levodopa can cause neuroleptic malignant syndrome. And in later stages of the Parkinsonism, these patients can have cognitive decline and as well as dementia. In atypical Parkinsonism, progressive supranuclear palsy, you will have vertical gaze palsy due to superior colliculus involvement. Electrooscillography shows square wave jerks, hummingbird sign in the MRI, and not very good response with levodopa. Multiple system atrophy, there will be autonomic insufficiency. MRI will show you hot cross bun sign. And we have a MSAC where there will be cerebellar ataxia. And corticobasal degeneration, these patients, they will have alien hand syndrome, and the MRI will show you that there is pathology within the corpus callosum. And dementia with Lewy body, you will have the cognitive impairment. That will be followed by the features of development of Parkinsonism. MRI will show you generalized atrophy, and for cognitive impairment, you need to give rivastigmine. Okay, so that finishes the topic of the Parkinsonism. Yes, staff, or yes, anosmia will be the earliest finding. The earliest finding in Parkinsonism will be anosmia. Okay, right. Now we'll move on to the discussion of the next important topic, that is the epilepsy. So if you take this, the epilepsy, why is this mainly due to? This is due to abnormal electrical activity within the brain. And what is the pathophysiology? There is hypersynchronous discharge of the cerebral neurons. There will be release of excitatory neurotransmitters, that is glutamate and as well as the aspartate. And there will be reduced inhibitory neurotransmitters, that is GABA. So there will be increase in excitatory neurotransmitters, that is glutamate and aspartate. There will be decrease in inhibitory neurotransmitters, that is GABA. Types, if you see, generalized, focal, and as well as psychogenic. Generalized, which involves both the hemispheres. Focal, there is involvement of only one hemisphere. Psychogenic, it is not caused by any abnormal cortical activity. It is often stress related. And if you take generalized seizures, the most common in adults, most common in adults will be rigidity. Most common in adults will be generalized tonic-clonic seizures, where there will be tonic, that will be rigidity. That will be followed by clonic, where there will be rapid jerking of the extremities. Absence seizures, which is very common in children. There will be brief loss of consciousness and there is no postictal confusion. Atonic or myoclonic, where there will be sudden loss of muscle tone and there will be abrupt fall in the individual. Then focal seizures. In case of the focal, there is no impairment of consciousness in simple focal seizures. Whereas in complex partial seizures, there will be altered consciousness, right? And along with this, this is very, very important, automatisms. Automatisms are very, very common in case of the complex partial seizures. And we have a terminology called status epilepticus, where the seizure activity will be there for more than 30 minutes. Multiple episodes of seizures will be there without gain of consciousness for more than 30 minutes. Or one particular episode will be there for more than 5 minutes. That is what is your status epilepticus. And the common reason for the development of status epilepticus is mainly due to discontinuation of the anti-epileptics. And what exactly is the drug of choice? That is lorazepam 0.1 to 0.4 milligram per kg body weight has to be given as a drug of choice in case of the status epilepticus. And we have some epilepsy syndromes, that is juvenile myoclonic epilepsy, where the individual will have the myoclonic jerks. Along with that, there will be development of generalized tonic-clonic seizures. And these myoclonic jerks are mainly seen within the upper extremities, and they are very common early in the morning in patients with the juvenile myoclonic epilepsy. And drug of choice in case of juvenile myoclonic epilepsy will be valproic acid, and EEG will show you, right? EEG in case of juvenile myoclonic epilepsy will show you that is 4 to 6 hertz irregular polyspike activity. And another important epilepsy syndrome will be Lennox-Gastaut syndrome. In patients with Lennox-Gastaut syndrome, you will have multiple seizure types, and there will also be cognitive impairment as well. And one more important epilepsy syndrome will be West syndrome, where the individual will have like salam seizures, which we call it as the infantile spasm. And on EEG, you will notice that there is hips arrhythmia. And how will you work up these patients with the epilepsy? That is by EEG. So when you do EEG in patients with absent seizures, that will show you 3-head spike and wave pattern. Whereas CT and MRI has to be done in order to rule out if there is any structural abnormalities causing the epilepsy. And metabolic workup, that is mainly you need to check for serum urea and creatinine, because uremic encephalopathy can cause epilepsy. Electrolyte abnormalities, that is hyponatremia, can cause epilepsy. So metabolic workup is very important. And for generalized seizures, the drug of choice will be sodium valproate. Alternative molecule will be levetiracetam. For focal seizures, drug of choice will be carbamazepine, and alternative will be lamotrigine. And absent seizures, less than 4 years, you need to give ethosuximide. And after 4 years, you need to give valproic acid. Very important, you need to avoid the triggers like the sleep deprivation. That is very, very important in the treatment of the absent seizures, right? And in pregnancy, very important consideration that you need to remember is you need to avoid the valproate. Why? Because valproate intake can cause a teratogenic adverse effect, that is focal tube defects, right? Where there will be neural tube defects. Neural tube defects are very common in case of the patients who are taking the valproate. Okay. And in case of status epilepticus, as already I have said you, the drug of choice will be lorazepam followed by phenytoin. And in refractory epilepsy, you need to give ketogenic diet. The diet that you should give is ketogenic diet. And in patients with the epilepsy, one of the very important complications is SUDEP. What is SUDEP? Sudden unexpected death in case of the epilepsy. And another important complications that you can come across is cognitive impairment and psychiatric disorders like depression as well as anxiety. So these will be the important points related to the epilepsy, right? So this finishes the topic of epilepsy, which are the very, very important points. And yes, what is that we give the ketogenic diet? It is the high protein diet. Okay, Shanavaz, it is a high protein diet. Okay, it's a high protein diet which we give in case of the ketogenic diet. Done. We'll move on to the cranial nerve abnormalities. We have done with the epilepsy. Now we'll move on to the cranial nerve abnormalities. So two important cranial nerve abnormalities will be the facial nerve abnormality, and the other one is the trigeminal neuralgia. The juvenile epilepsy, it is commonly observed in children 15 to 20 years. That is what is your juvenile epilepsy. 15 to 20 years is your juvenile epilepsy. Okay, right. Now, let me discuss the facial nerve abnormality and trigeminal neuralgia. Okay, so if you take this particular, the facial nerve abnormality, this facial nerve, it's a mixed nerve. That means you have motor and as well as the sensory abnormality. What will be the motor manifestations? Motor manifestations will be in the form of muscles of the facial expression, they lose their activity because of the involvement of the facial nerve. Okay, so muscles of the facial expression, stapedius, which is there in the middle ear, and as well as posterior digastric, these are all supplied by your motor component of the facial nerve. Sensory component of the facial nerve, it is mainly concerned with the taste. And that particular taste, it is brought by the caudate tympani nerve, which is a branch of the facial nerve, and that is mainly from the anterior 2/3 of the tongue. And what is the function of the facial nerve now? That is for facial expression, eyelid closure, and stapedial reflex, which will dampen the high intensity sound. And sensory sensations will be taste sensations from anterior 2/3 of the tongue, and parasympathetic sensation, it is mainly concerned with lacrimation as well as salivation. What is the most common cause for facial nerve palsy? Bell's palsy. And viral infections that can cause the facial nerve palsy will be herpes simplex infection and Ramsay-Hunt syndrome. And we have malignancies which can cause facial nerve palsy, that is acoustic neuroma. And some inflammatory pathologies that will be causing facial nerve palsies will be sarcoidosis, which is a non-caseating granuloma, and Guillain-Barre syndrome, which is an autoimmune condition. Right. In case of the facial nerve, you have upper motor neuron and as well as the lower motor neuron. So if you take the upper motor neuron lesion, you will have contralateral lower face paresis, and upper half of the face is completely spared. Whereas in lower motor neuron lesion, you will have ipsilateral upper and lower half paresis. I'm telling you, this is very, very important. Right? This is very, very important. So in upper motor neuron lesion, you will have contralateral lower half paresis, lower face paresis, whereas in lower motor neuron lesion, ipsilateral half, upper and lower half of the face is completely paralyzed. Okay. Now, coming to the Bell's palsy. So Bell's palsy, what did I tell you? That is the most common cause for the facial nerve palsy. And it is an acute unilateral idiopathic paralysis. Acute unilateral idiopathic paralysis. And symptoms that you will have in patients with the Bell's palsy will be stiff face, drooling of the saliva, difficulty in closure of the eyelids, and there will be the impairment of the taste sensation. Okay. And diagnosis, it is always diagnosis of the exclusion. You need to rule out other causes, and then you need to consider Bell's palsy as one of the diagnoses. And how will you diagnose Bell's palsy? That is by nerve excitability test and as well as the electromyography. That is mainly to monitor the degeneration of the facial nerve. Okay. And you need to do topo diagnosis in order to look for where exactly is the site in the entire course of the facial nerve that is being damaged. And if the individual presents to you within 72 hours of the onset of the clinical manifestations, the drug that we give is prednisolone. And the individual is unable to close the eyes. So artificial tears in order to prevent the xerosis, and lubricants to protect the cornea, and physiotherapy and as well as the nerve decompression has to be done if required. And how is the prognosis in Bell's palsy? 85 to 90%, they'll have good prognosis. But some individuals, they have poor prognosis. They are the one with advanced age, those individuals who are having severe pain, those individuals where there is damage to stapedius causing hyperacusis, and where there is complete facial palsy, they are said to be having poor prognosis. Okay. And recurrence, it is less common, not very common. Okay. And some specific syndromes are there related to facial nerve, and that is Melkerson's-Rosenthal syndrome, where you have a triad. What is a triad in Melkerson's-Rosenthal syndrome? Where you have facial nerve palsy, lip swelling, and as well as the fissured tongue. These are the specific syndromes in case of Melkerson's-Rosenthal syndrome. And one more important syndrome is Mobius syndrome, where you have congenital, bilateral, facial, and as well as the abducens nerve palsy. Both 7th and as well as 6th nerve palsy will be there. So this is about your 7th cranial nerve involvement. So let me just quickly recap 7th cranial nerve palsy. In 1 minute, I finish. So 7th cranial nerve, it's a mixed nerve. What will be the causes of the facial palsy? Most common, Bell's palsy. Infections, herpes simplex. The other conditions, Ramsay-Hunt syndrome. Neoplastic conditions, acoustic neuroma, right? And in upper motor neuron lesion of the facial nerve palsy, you'll have the features like contralateral lower half of the face is paralyzed, upper half spared. Lower motor neuron paralysis, ipsilateral, entire half of the face is paralyzed. Bell's palsy, it is acute unilateral idiopathic paralysis. Diagnosis, it is always by exclusion. The other ways by which you can diagnose is by nerve excitability test and electromyography. If the patient presents to you within 72 hours, you give prednisolone. For eye care, you need to give artificial tears and as well as lubricants mainly to protect the cornea, right? Prognosis, 85 to 90% of them, they'll have good prognosis. Poor prognostic features will be those individuals in advanced stages developing Bell's palsy, severe pain, hyperacusis. Specific syndromes, Melkerson's-Rosenthal syndrome, where you have a triad of recurrent facial nerve palsy, lip swelling, and fissured tongue. Mobius syndrome, congenital bilateral facial, and as well as the abducen nerve palsy, right? So that is about the facial nerve palsy, right? Clinical condition, that is the trigeminal neuralgia. So this will be like after trigeminal neuralgia, you have one more, that is subacute combined degeneration of spinal cord, and then we'll wind up the session. Coming to the trigeminal neuralgia. So trigeminal neuralgia, what exactly is the problem here? There is damage to all the three branches of the trigeminal nerve: ophthalmic, maxillary, and mandibular. Motor involvement will be there, sensory involvement will be there. Characteristic presentations will be, these patients, they present with intense, sharp, electric shock-like sensation will be there in the distribution of the trigeminal nerve. And it is more common in women rather than men. And it is very typical at the age group of 50 years. And what is the etiopathogenesis? It is mainly due to compression of the trigeminal nerve root. And this compression of the trigeminal nerve root, it is either by tumors or it can be also seen in patients with multiple sclerosis. So characteristic features will be severe pain, electric shock-like sensations will be there for a few minutes, right? And the pain is more common in the phyto, maxillary division, or in the mandibular division. And the pain which is being described by the individual is like electric shock-like sensation. And these patients, they will have the facial spasm due to the motor involvement of the trigeminal nerve. And if there is facial spasm, that we call it as tic douloureux. There are some triggers for the development of trigeminal neuralgia. And that includes the following: light touch, chewing, talking, like kissing, brushing, exposure to cold air, and as well as smiling. And these patients with trigeminal neuralgia, they can also have autonomic symptoms. But autonomic symptoms are commonly present only in 5-1 distribution. And that particular autonomic symptoms will be like lacrimation, redness, and as well as rhinorrhea, running nose. And so diagnosis is mainly clinical. MRI is mainly done mainly to exclude the secondary causes like tumors. And how do you treat? Drug of choice, right? Drug of choice will be carbamazepine. That will be the first line molecule. Drug of choice will be carbamazepine. That is a first line molecule. Followed by that, the other drugs that we give is gabapentin and as well as the baclofen. And surgical treatment will be microvascular decompression. When will you do microvascular decompression? It is only in refractory cases where the individual is not able to tolerate the medical therapy. Then you need to do microvascular decompression and stereotactic radiosurgery, right? Stereotactic radiosurgery and as well as percutaneous rhizotomy has to be done. That is a surgical treatment. How will be the prognosis in these individuals? With conservative management, there is high recurrence rate. Okay, but when surgical treatment you do, there will be relief in almost 75% of patients. There will be 75% of patients. Yeah, if the patient is not responding to carbamazepine, Shinavas, you can give oxcarbamazepine. Or the other alternative drugs are gabapentin and as well as the baclofen. Yeah, what is rhizotomy? Rhizotomy is nothing but the trigeminal nerve root is cut off. Trigeminal nerve root is being cut off. So that is about trigeminal neuralgia. So let me just quickly recap the entire trigeminal neuralgia in just 1 minute. So trigeminal neuralgia, where you have intense, sharp, electric shock-like sensation in the distribution of the trigeminal nerve. More common in women rather than men. Right? And mainly due to the trigeminal nerve root compression by the tumors. And the clinical features are mainly in phyto, maxillary division, and then mandibular division. And pain will be like electric shock-like sensation or stabbing-like sensation. And if there is facial muscle spasm, that we call it as tic douloureux. Triggers will be like light touch, chewing, smiling, and as well as brushing. Autonomic symptoms where there will be lacrimation, tearing, and that will be mainly in the 5-1 distribution. And diagnosis is clinical and MRI is done to rule out if there is any tumors. Management drug of choice, carbamazepine or oxcarbamazepine can be given. The alternative drugs are gabapentin and baclofen. In refractory cases, you do microvascular decompression and stereotactic radiosurgery or percutaneous rhizotomy. If conservative management is followed, high recurrence rate. If surgical treatment is done, 75% of individuals, they'll have long-term relief. Okay, so that is about your trigeminal neuralgia. Okay, so we'll move on to the next topic, that is subacute combined degeneration of the spinal cord. So if you see the subacute combined degeneration of the spinal cord, this is mainly due to vitamin B12 deficiency. And this vitamin B12 deficiency will not only cause the neurological abnormality, there will also be development of megaloblastic anemia. And in the neurological abnormality, the tracts which are affected are mainly the posterior columns, which are also called dorsal columns, and the pyramidal tracts are being affected. And the neurological manifestations due to the posterior column dysfunction, that will be loss of proprioception, vibration sense, dorsal column sensations are being lost. And due to the pyramidal tract involvement, these patients will have spasticity. In very late, there will be peripheral neuropathy as well. And in subacute combined degeneration, do you have any optic cranial nerve involvement? Yes. These patients, they can have optic nerve atrophy. And the mental symptoms will be in the form of the irritability and as well as apathy. And that is due to demyelination of the cerebral neurons. There will be irritability and apathy. When you do MRI in patients with subacute combined degeneration of spinal cord, this will cause T2 signal hyperintensity. And the T2 signal hyperintensity is very common in the posterior and as well as the lateral columns. And how will you work up? When you do serum B12 levels, you find that there is low serum B12 levels. And due to B12 deficiency, the homocysteine levels are being elevated. And how do you treat these patients with subacute combined degeneration of spinal cord? You need to give cyanocobalamin. And this particular cyanocobalamin, you should give it intramuscularly for 1 week. Then weekly you need to give for 1 month. Then monthly you have to take for life. Okay. And for maintenance, what you can give is oral methylcobalamin can be given. And how will be the prognosis? Remember, whenever you are treating the anemia, it responds well to the treatment. And even in the neurological symptoms also, it is ataxia and as well as the sensory signals or sensory signs, they improve if you treat the patient early, right? And late complications like spasticity and dementia, that will often persist. But symptoms like ataxia and sensory signs, they improve if you treat early, right? So commonly asked questions in subacute combined degeneration of spinal cord, it is the posterior columns, pyramidal tracts which are affected, in late stages peripheral nerves, okay? And it has to be differentiated from the multiple sclerosis. So this is about subacute combined degeneration of spinal cord, okay? So let me just quickly recap the entire subacute combined degeneration of spinal cord in 1 minute. So subacute combined degeneration of spinal cord is mainly due to vitamin B12 deficiency. That will be causing demyelination of dorsal columns and pyramidal tract. And vitamin B12 deficiency will also cause megaloblastic anemia. And due to posterior column involvement, there will be loss of proprioception and vibration sense. Due to pyramidal tract involvement, there will be weakness and spasticity. And late involvement will be peripheral neuropathy. Common cranial nerves which are affected is the optic nerve causing optic nerve atrophy. Mental symptoms will be in the form of irritability. And investigations, if you see, MRI will show you that there is increased T2 signal hyperintensity. Blood test, if you see, low serum B12 levels. And treatment, you need to give the cyanocobalamin. Intramuscular injections should be given. So weekly, 1000 micrograms, then for 1 week complete, then followed by the weekly once for 1 month, then monthly once for the rest of the life. Okay. Prognosis, anemia responds well. Neurological symptoms like ataxia and sensory signs, they improve if you treat the patients early. Late complications like spasticity and dementia, they often persist. Okay. So that is about subacute combined degeneration of spinal cord. Now, we'll move on to the next topic. So shall I continue for a few more topics? The Alzheimer's is there, and cerebrovascular accidents like aphasia is there. So shall I continue with Alzheimer's? Okay, I'll continue and then we'll wind up this session. Right. Now coming to the Alzheimer's. What exactly is the problem in the Alzheimer's? It is the decline in the intellectual function of the individual. Decline in the intellectual function of the individual. And you have to differentiate this from delirium. Both are different. And what type of dementia that you have in case of the Alzheimer's? It is cortical dementia. Actually, you have various types of dementia, right? That is cortical, subcortical, and as well as mixed. But Alzheimer's, it is the cortical dementia. Which part of the cortex is affected in Alzheimer's? It is the temporoparietal lobe, which is commonly affected. Within the temporoparietal lobe, it is the hippocampal formation that gets affected very badly in these patients. Okay. And if you take the etiology, it is majority, it is like sporadic, like spontaneous, but 5% it is autosomal dominant type of inheritance. And what are the abnormal proteins which are accumulated within the hippocampus? we have amyloid precursor proteins that include presenilin 1 and amyloid precursor protein, presenilin 1 and presenilin 2. Please remember, presenilin 3 is not involved. What are the risk factors? Very important is age of the individual, family history, low education level, and trisomy 21. These are the risk factors. What will be the pathological changes that you observe? You will notice that there is widespread cerebral atrophy, especially in the cortex and hippocampus. And when you do histopathological diagnosis, you will find that there is presence of neurofibrillary tangles and as well as beta amyloid plaques, out of which the neurofibrillary tangles, they are intracellular, right? And the neurotransmitter deficiency that you commonly observe in these individuals will be acetylcholine deficiency will be there. That is a main deficiency. The other neurotransmitters that are being defective will be noradrenaline, serotonin. But please remember, dopamine is not decreased in case of the Alzheimer's. And clinical features that will be in the form of memory loss, and there will be difficulty in word finding. And how will you diagnose? That is by MMSE, that is mini mental state examination. Or you have other scoring systems, that is Montreal Cognitive Assessment, that is MoCA. Or you need to do MRI or PET in order to look for the presence of any structural pathologies. Okay. And what is the treatment that you need to give? Cholinesterase inhibitors, because acetylcholine is reduced. So when you give cholinesterase inhibitors like donepezil, galantamine, and as well as rivastigmine, that will increase the acetylcholine levels, right? And memantine, it has to be given for the moderate to severe cases. So in mild cases, we give donepezil, galantamine, or rivastigmine. Memantine is given in moderate to severe cases of the Alzheimer's. What are the new treatment options that you have? The new treatment options that you have is aducanumab, which is an antibody which is formed against the beta amyloid, right? And we have some non-pharmacological approaches also, and that include doing the aerobic exercises and frequent mental stimulation to reduce the functional decline. So that is about the Alzheimer's disease. Okay, so let me just quickly recap the Alzheimer's in just 1 minute. Alzheimer's, decline in intellectual function. It is the cortical dementia. Which lobes affected? Temporoparietal lobe, right? And that is mainly the hippocampus formation. Majority of them sporadic, 5% autosomal dominant type of inheritance. Pathological proteins which are accumulated in the temporoparietal lobe will be amyloid precursor protein, presenilin 1 and presenilin 2. Risk factors are mainly old age, positive family history, female gender, low education status, right? So you'll have widespread cerebral atrophy. And histopathological finding will be neurofibrillary tangles and beta amyloid plaques. And these neurofibrillary tangles are mainly intracellular. And the very important neurotransmitter that is being deficient is acetylcholine. And the important clinical manifestation will be memory loss. And apart from that, word finding difficulty and visuospatial dysfunction also can be there. Diagnosis is mainly by MMSE and as well as MoCA. That is Montreal Cognitive Assessment, MoCA. Management, cholinesterase inhibitors like donepezil, galantamine, rivastigmine in mild cases for cognitive symptoms. In severe cases, we give memantine. New treatments are the aducanumab, right? So this is about your Alzheimer's disease. The last topic that I will take up is the aphasia. Aphasia. So what are the types of aphasia? Wernicke's, Broca's, conduction aphasia, and as well as the anomic aphasia. Wernicke's aphasia, where your Wernicke's area is damaged. That is the reason why there will be impaired comprehension, because Wernicke's area is concerned with the comprehension. But the speech will be fluent speech, and it's a nonsensical speech. You will have neologisms. So the fluency, right? So the fluency will be maintained. So the affected area will be the Wernicke's area, which is present in the posterior superior temporal lobe, right? Next, Broca's aphasia, which is the motor part of the speech. Wernicke's area is the sensory part of the speech. Broca's area is a motor part of the speech. So Broca's area, once it is gone, the motor output is lost. So the individual will have non-fluent aphasia. But how is the comprehension? Comprehension will be intact because Wernicke's area is intact. Coming to conduction aphasia. Connecting this Wernicke's area and Broca's area, you have the arcuate fibers. So arcuate fasciculus is being damaged in case of conduction aphasia. The important problem in these patients will be the impaired repetition. But how will be the comprehension? The preserved comprehension, right? And fluency is also being preserved, but the repetition is being impaired. Next is anomic aphasia. Anomic aphasia is that where the individual will have difficulty in finding the words. The speech will be fluent speech. And which part of the brain is gone? Diffuse cortical areas, you will have the damage. That is anomic aphasia, where you have difficulty in finding the words. Lastly, you have global aphasia. What is this global aphasia? Global aphasia is that where your Wernicke's area is gone, arcuate fibers are gone, Broca's area is gone. So there will be severe impairment of all language functions, and it's a non-fluent speech. So what are all your non-fluent now? Broca's aphasia, global aphasia, non-fluent. Whereas Wernicke's aphasia, conduction aphasia, anomic aphasia, that is fluent, right? And there is extensive damage to the dominant hemisphere, usually the left cerebral hemisphere. Okay, so this is about the aphasias, right? So with this, I'll wind up this particular session. Tomorrow I will take one more session, that is from 7:30 or 8:30. I will inform in my Telegram channel, either 7:30 or 8:30. So I will finish the nephrology, another very important system. Then I will finish the endocrinology. Okay, so these are the two topics which will be due. Already I have finished the hepatology, connective tissue disorders, and then what was the other one? Connective tissue disorders, hepatology I have done, and one more respiratory system I have done. Neurology I have finished now. So tomorrow I will take up this nephrology and endocrinology. With that, the rapid revision will be completely done, right? I hope the session was useful. Please revise. This will be very much useful just before going to your exam, right? Thank you very much.